Ryan's gone. You want to shout?
Great. Welcome back, everyone, to House Healthcare. We are taking care of our temperature needs here, and we are going to transition now to the COVID-19 healthcare regulatory flexibility bill that we've been reviewing. We're going to have Jen walk us through where we are to date, and then we'll have a committee discussion. Okay. Lee, can you pull it up on the screen? And also it is posted on our website.
Actually, the website link isn't working.
Yeah, that's what I.
You have to refresh the page. I had to do
Yeah, I
that.
think I got mine.
Okay, sorry.
Oh, it's okay. I don't make sure.
No, it's still not working, so.
Go all the way out.
Go all the way out and come back in.
Oh, I got you.
Yeah.
Purity measure.
Great. Jen, we'll turn it over to you.
Great. Good morning. Jen Kirby, Legislative Counsel. So I'm going to put this language up on the screen. Make sure it works. Yes, great. All right. So we are looking at what I've called draft 3.4 of the committee bill. I've added some, so I tried to show, I think, the new language since the last time we looked at it in blue highlighting. I've kept the earlier yellow stuff for the advanced directive language and other sections that the Human Services Committee needs to review. So that's the method behind my coloring here.
So can I just, sorry, to clarify, so for our committee purposes, the new language is blue. And then everything else we've been through with our stakeholders, and that is no longer highlighted, correct?
I believe so.
Okay, great.
We'll look as we go through.
Yep.
So I've added a couple of additional descriptors in the statement of purpose, because since this is a committee bill, the statement of purpose of the bill as introduced should reflect what is in the bill when it is introduced. So I added that it would continue pharmacists' authority to order and administer COVID tests. And then the new language we're gonna look at for your discussion today is on modernizing aspects of the practice of radiologist assistants. Just trying to come up with a way to describe that they're fairly small changes. All right, and then throughout, I added these reader assistance headings just so that you can tell, they won't be in blue anymore once we've looked at this, but so that you can tell, or the reader can tell, what the general topic of the section or sections is. So the first one is still that extension of the COVID-19 healthcare regulatory flexibility. And these are the amendments to Act 91 for 2020 as amended by a variety of acts since then. So the first section is the extension for a year of the healthcare and human service provider regulation flexibility. This is the AHS, Agency of Human Services, rules, standards that the secretary can waive or permit variances from. So the only change to that actual language is just the date change. Similarly, we have the Green Mountain Care Board waiver and variance allowed from their rules. And after your conversation last time, there's no additional language. This would just be a straight extension for a year of the board's authority to waive or permit variances from state laws, guidance, and standards with respect to regulatory activities as needed to prioritize and maximize direct patient care, safeguard the stability of healthcare providers, and allow for orderly regulatory processes that are responsive to evolving needs related to the pandemic. And that's specifically around hospital budget review, certificates of need, health insurance rate review, and ACO, Accountable Care Organization, certification and budget review. Then we have the extension in section 6 of the original act, the extension for a year of the provider enrollment and credentialing requirements in Medicaid and private insurance plans to allow providers to deliver and be reimbursed for services across settings. Section 8 of Act 91 is extending the DFR, Department of Financial Regulation, emergency rulemaking authority. And the first change here is really just the same date until April 1st versus through March 31st, but everything else has been using March 31st, so it seemed a little confusing. April 1st. So through March 31st of 2024, allowing DFR to consider adopting and have the authority to adopt emergency rules And now narrowing the focus just to expanding health insurance coverage for waiving or limiting cost sharing requirements directly related to COVID-19 diagnosis, treatment, and prevention. It takes out that same authority with respect to deductible requirements for prescription drugs. Then we're in the regulation of professions sections. Section 17 of Act 91 as amended. This is the out-of-state healthcare professionals. So this again would extend through March 31st of 2024. This deemed licensure that we've talked about, where a healthcare professional who holds a valid license, certificate, or registration to provide healthcare services in any other U.S. jurisdiction would be deemed to be licensed, certified, or registered to provide services here in Vermont. You have limited it with the language on lines 11 through 14 to just professions regulated by the Board of Medical Practice or a profession regulated by the Office of Professional Regulation for which the office does not provide a pathway to provisional licensure. So this is again a narrowing as other circumstances have evolved. So this is to provide services to a patient located in Vermont as a volunteer member of the Medical Reserve Corps or for up to 6 months as part of the staff of a licensed facility or other healthcare facility or federally qualified health center. And then it maintains that language around them remaining licensed, certified, or registered in good standing in all the other places they are licensed. I'm just going to say licensed. It includes certified and registered for these purposes. They're not subject to any professional disciplinary proceedings anywhere else, and they're not affirmatively barred from practice in Vermont because of fraud or abuse, patient care, or public safety. It retains this existing requirement that they submit their name and contact information and where they will be practicing to the Board of Medical Practice or OPR as applicable for their profession. Still has them subject to the imputed jurisdiction of the Board of Medical Practice or OPR as applicable based on their profession. And this section remains in effect now. This extends through March 31st, 2024, as long as they remain licensed in good standing throughout that period, which again is not to exceed 6 months for someone who's working at a facility or FQHC. And it extends the date by a year by which the board of which the Board of Medical Practice and OPR have to provide appropriate notice at the expiration date, both to the providers and to the facilities they're providing at. And then you have new language. So I think I did leave this in highlighted now in yellow, confusing, but I looked at it before, but I wanted to see it because I think we talked about it more than we looked at it. Healthcare facilities, health insurers, and Vermont Medicaid shall consider deemed licensure, certification, or registration pursuant to this section as sufficient to meet applicable Vermont licensure, certification, or registration requirements for the purpose of healthcare professional credentialing and enrollment, provided, however, that this deemed satisfaction of the licensure, certification, and registration requirements shall have no impact on any other credentialing or enrollment requirement. So this was the language you'd put in to say deemed licensure satisfies the licensure piece of credentialing or enrollment, but nothing else. Then we get to telehealth, specifically in the Act 91 provisions. And this again extends for an additional year provisions requiring telehealth, telemedicine, or going forward health to be provided using a HIPAA compliant connection. This is again only to the extent that their waiver is permitted by federal law or guidance regarding enforcement discretion. So you've heard that when the public health emergency ends at the federal level on, I believe the date was May 11th, the expectation is that this flexibility will go away as well. But to the extent that it is allowed under federal law, it would be allowed under Vermont law through March 31st of next year. All right, then we get to section 2 of the bill. So we're still in some of the COVID flexibility provisions, but it's a different act that was being amended. It was the original act. And this has to do with the Board of Medical Practice and temporary provisions relating to physicians, physician assistants, and podiatrists. So again, extending for an additional year the authority of the Board of Medical Practice or its executive director to issue a temporary license to a physician, physician assistant, or podiatrist who's licensed in another jurisdiction, whose license is in good standing, and who is not subject to disciplinary proceedings. And so it also has that same date extension for the authority to waive requirements for physician assistants as appropriate. Then, because it is ongoing authority, I changed this to be maintaining pharmacist authority to order and administer COVID tests. So this is the language that or the provision that strikes out the sunset on the pharmacist's authority to order or administer COVID tests. By repealing the sunset before it takes effect, you would be keeping this provision of statute in effect on an ongoing basis.
Can you say that again?
Yes. So what you can't see from section 3 or section 12A that it is amending is that there is an existing statute that is referenced on line 16, 26 VSA section 2023 B2A Romanet 10 on clinical pharmacy prescribing, specifically a state protocol around COVID testing, SARS-CoV testing. That provision of the statute is currently scheduled to be repealed, what we sometimes call a sunset, scheduled to sunset on March 31st, 2023. You would be striking out this sunset. So you would be repealing the repeal before it happens, which you can do. You can't repeal or repeal after it happens. Once it's been repealed, it's gone. You have to reenact it. You have to do it again. But in this case, because it has not been repealed yet, the authority would continue on an ongoing basis because you're basically undoing the repeal. You're saying
Basically undoing the sunset.
undoing the sunset before it happens. So sun's on its way down, but it's not down yet. All right, sun goes back.
Could we, instead of doing that, could we change 2023 to 2024?
You could, sure, you could push it out. That's what's happened the last couple of years, is that you
Okay.
have pushed out the sunset. And this
Okay.
committee had a conversation and said, you
So-
didn't see any reason that it needed to be revisited. Just keep it in place.
Okay, so what we're saying with this is that this will be an ongoing thing. They'll be always able to.
Exactly. So 2025, 2026, whenever, the pharmacist would be able to order and administer
Okay,
COVID tests.
all right, okay.
Unless
Yeah,
the
yeah.
legislature
unless you
come
wanna
back and change something.
relook at it.
Exactly.
Okay.
Exactly.
Since we don't have to ever look at it again.
Exactly.
Unless we decide we want to.
Exactly. You get to set it and forget it here unless you want to come back and look at it. But it
I
won't.
like that one, set it and forget. That's,
I want you to know what happened.
I think it might actually be the old crock pot slogan or something.
Sunsetting, crock pot. All right, everyone good with that for the moment? Okay.
All right, now we get to extending temporary telehealth registration. This was a new section we looked at last time that was amending a provision that you enacted last year. And this is the temporary telehealth registration for out-of-state healthcare professionals. So those of you who were here last year may remember that you created a whole telehealth licensure and registration process for out-of-state healthcare professionals. And you did a transitional provision so that there would be a slightly more robust than what was happening before registration process in the interim while Board of Medical Practice and OPR were getting the telehealth and registration systems ready to go. There has been some concern expressed to you that those systems may not be ready to go on July 1st, which is when they're scheduled to begin. So this would say, notwithstanding any provision of our licensure laws or rules to the contrary, this is the existing law, but instead of saying this temporary telehealth registration is going to exist for this finite period of April 1st, 2022 to June 30th, 2023, so we're in it right now, this temporary telehealth, you're just saying beginning on April 1st, when it actually did begin, OPR and the Board of Medical Practice will register a healthcare professional who's not licensed or registered to practice in Vermont, but who seeks to provide services to patients or clients located in Vermont using telehealth. So they will be registered as long as they complete an application in the manner specified by the Director of OPR or Board of Medical Practice. They hold an active unencumbered license, certificate, or registration in at least one other U.S. jurisdiction to practice that profession that they're planning to seek here or provide here. Their license, certificate, or registration is in good standing in all other U.S. jurisdictions where they are licensed, certified, or registered, and they provide verification of that licensure, certification, or registration to OPR or the board. So we took off the automatic end date of June 30th, and instead it says the temporary telehealth registration option available pursuant to this section shall continue to be available to out-of-state healthcare professionals until the telehealth licensure and registration system established in 26 VSA Chapter 56, that's what you set up last year, or the legislature, by 2022 Acts and Resolves number 107 is operational. So this temporary telehealth registration option will continue to be available until the real telehealth licensure and registration system is operational. And it requires OPR and the Board of Medical Practice to provide appropriate notice to healthcare professionals who are registered under this section of the expiration date of the temporary telehealth registration option. And so they have to say it's going to expire soon, and they shall allow temporary telehealth registrants 90 days, and then this is a clarification suggested by the Board of Medical Practice, following the effective date of the applicable telehealth licensure and registration rules to transition from temporary registration to a telehealth license or registration. So the recommendation was to tie them, I think we talked about 90 days to transition to something else, but Board of Medical Practice suggested that that should be the effective date of the rules that they set up. That's really kind of what makes the new system operational to transition from this temporary registration to something else.
Leslie?
I'm not sure I'm understanding, sorry. So licensure and registration rules have to go through LCAR. Is that what they're saying? So once it's okay by LCAR, then it's okay?
Well, there will be an effective date in the rules. So all proposed rules need to have an effective date when they would take effect. So going through LCAR is part of the process of adopting rules, but there's a lot of process that happens before then, and there's some process that happens after then.
So how does one know the ultimate end date with that whole?
Because it's in the proposed rule itself. It will say what its proposed effective date is.
And who decides that, OPR or Board of, who, the effective date, who writes the rule then?
Board of Medical Practice for the professions they regulate and OPR for the professions they
So each
regulate.
of those will write their own rule that has to
Yes.
go through the process.
Yes.
Now theoretically, they'll do it together or not. They could have separate rules and
They could have separate
we don't
rules.
care. Okay.
Different professions.
Yeah. All right. Thank you.
How does the provider get paid? If the provider from Massachusetts is providing services to me and my insurance is here in Vermont, how does that person get paid?
Well, they would have to file the claim. Typically, they would file the claim with your insurance. They would have to be registered, they would have to sign up with your insurance if they were not already a participating provider in that plan, depending on the insurer. Some of them have nationwide networks or some combination of nationwide or rental. They rent each other's networks. There's all sorts of varieties of ways, but it may matter to the patient whether the provider is in network in choosing which provider to see. Or patients can pay out of pocket. Sometimes they pay out of pocket and get reimbursed by insurance or reimbursed at the out of network rate. So it's sort of the same as any other provider, but it's the provider's role to follow up with either the payer or the patient to get paid. I don't know if your folks on that side of the room have any other thoughts. All right.
Good.
So it's just for telehealth, though?
Sorry.
It's for telehealth
It's
services?
this section of the bill.
Yeah.
Yes, this section of the bill is just for telehealth, and it's really for telehealth generally provided by somebody who is not a Vermont provider.
Right.
Because if they were a Vermont provider, unless they were exclusively using, delivering services by telehealth, they would have a full license and they wouldn't have to go through this. So we're really talking about out-of-state providers.
Yeah. So if I went in person this wouldn't cover them, right?
If you went to the doctor in person here in Vermont, they'd already be licensed.
Oh, sorry.
Like if you went to a doctor in Massachusetts.
Yeah.
They wouldn't need to be, if you're located in Massachusetts when you're seeking the services, then they need to be licensed in Massachusetts, and Vermont doesn't have any role in that.
Okay.
Okay. So that is that section. Now we will, you want me to just run right past the advanced directives?
Yes.
All right, advanced directives. Buprenorphine. Talk about buprenorphine, keep
Nope.
Okay. All right, so these are there's two new potential sections for you to look at in this, what I've given the heading of radiologist assistance. I don't know if you want to give any
Yeah.
background on.
Why? Yes. So thank you. I will. So, and we will have, depending on how the conversation goes today, we will have witnesses. So University of Vermont Medical Center approached me about these two sections around radiologists. And when they come in, they can explain better than I can. But basically, when they approached me, I felt it was worthwhile for our committee to review because it does lead to access to care with radiologists. So with everything else, there's a limited workforce. They are seeking a change, and Jen will describe it better when she goes through the language, but they are basically seeking a change to the direct supervision provision that's required to allow it to be not just in person, but synchronous audio and or visual means. So I'm a little bit outside of my knowledge here, but for instance, I could be a radiologist and my supervision could be done via audio. So talking to someone in another facility rather than having to be in the same facility. And their point is that without that capability and with the fact that there's still COVID happening, so the workforce is still an issue, and being in the same building can still be an issue. They're asking for this change in this supervision, the way it's done. They're asking it to come through us, although they went through the Board of Medical Practice, and we will talk to them as well. The Board of Medical Practice, from my understanding, said really should be a change within the legislature. So we will make sure we bring Board of Medical Practice in as well. So that's one amendment. And so, you know what, let's hold questions.
It's about radiology assistants.
I know, but let's hold questions until I go, there's two sections. And let's have Jen walk through the language, and then let's do your questions. And again, we might have to punt the questions until we have.
It's not a question, it's a clarifying comment about radiology assistants.
Okay, hold on. So then the second finding, or the second proposal is that they allow the radiology assistant to communicate with the patients, not clinical findings of the exam. So a radiology assistant, we're not allowing them to say, oh, you know, we don't see any tumors. They are simply asking that we let them say we've been able to complete the test. You know, so I don't know who has ever had these type of tests, but you can often leave there not knowing if they were able to have it be completed in a way that a doctor is going to be able to provide a finding. And it's really unsettling from the patient's point of view to not know if you're going to have to come back for an exam. So I'm hoping I did that justice. We will, depending on how we move forward, have witnesses. So let's go to your comment, which may or may not be able to be clarified by me, and then we'll go to Jen.
I don't know if this is helpful anyway. It's just radiologist assistants in some ways. There's radiology techs that do the x-rays. They're the ones that help you get into the room to stand up in front of the x-ray machine and get your radiologist assistants are a higher level of training and schooling. And I don't think they're the same as physician assistants, but it's a similar relationship as a physician assistant with a physician and a radiologist assistant with a radiologist who is also a physician. So they have expanded scope from radiology techs. That might be helpful to understand why
Thank you. That was helpful.
this is coming forward.
Great. Thank you. Oh, okay. All right, Jen.
So this is the language. The first proposed change would be what I put in as section 9. And just to orient you, we are in the professional licensure statutes in Title 26. There is a chapter on radiologist assistants. And the first section in that chapter is definitions. And this would amend the definition of supervision. So the existing language says supervision means the direction and review by a supervising radiologist as determined to be appropriate by the board meaning Board of Medical Practice, of the medical services provided by the radiologist assistant. At a minimum, supervision shall mean that a radiologist is readily available, and that's what we're going to come back to, for consultation and intervention. A radiologist assistant may provide services under the direction and review of more than one supervising radiologist during the course of, should say, the radiologist assistant's employment. I've been trying to make these changes, so I will flag these for myself. Color, subject to the limitations on their scope of practice. Make these non-gendered, as set forth in this chapter and the protocol filed under subsection 2853B of this title. And then here's our new language. So that's all existing statute. This would say, as used in subdivision A of this subdivision 8, readily available. So remember, readily available means, whatever it was, means that a radiologist, so we're up here, at a minimum, supervision means that a radiologist is readily available for consultation and intervention. And what we mean by readily available means that a radiologist is available in person or is available remotely by telephone or through a live interactive audio and video connection.
I think that's,
And I have not had this edited, as you can tell, because they would have caught my gendered language. Section 10 would amend 26 VSA section 2857 around the supervision and scope of practice. And there's a lot of existing language in here that I put in here just so that you could see what it says. The number of radiologist assistants permitted to practice under the direction and supervision of a radiologist shall be determined by the board, again, Board of Medical Practice, after review of the system of care delivery in which the supervising radiologist and radiologist assistants propose to practice. Scope of practice and levels of supervision shall be consistent with guidelines adopted by the American College of Radiology, the American Society of Radiologic Technologists, and the AARRT. Can't tell you what that stands for. The authority of a radiologist assistant to practice shall terminate immediately upon termination of the radiologist assistant's employment, and the primary supervising radiologist shall immediately notify the Commissioner of the Department of Health of the termination. The radiologist assistant's authority to practice shall not resume until the radiologist assistant provides proof of other employment and a protocol as required under this chapter.
So can you stop and just tell us what that says in English?
It basically says the Board of Medical Practice gets to decide how many radiologist assistants a supervising radiologist can supervise. Their scope of practice and levels of supervision have to match or be consistent with what the kind of federal or national provider organizations set out. If a radiologist assistant stops practicing with a supervising radiologist, then the supervisor has to notify the board, and the radiologist assistant can't work again until they have a new supervising radiologist.
Right.
I've never seen that before where licensed health professionals' practice was limited by whether they were employed or not.
I think we had the same thing for physician assistants as well. There has to be that kind of supervisor. It's a little bit.
Relationship.
Yeah, we changed it a bit for the physician assistants, but I do still think because they're not authorized to practice independently, there has to be that relationship in order for them to.
On the basis of employment. I guess that would be the only way there would be a relationship is if they were employed.
they could have a contract or like an agreement.
I mean, yes, I think in order to be able to, this requires in order for them to be able to practice that they must have some sort of that they must be employed in their radiology assistant capacity, and that would include the supervising radiologist. So radiologist assistants cannot hang out a shingle and advertise their services. They have to be in that relationship, that employment relationship. They don't have to be employed directly by that radiologist, but there does have to be a connection between their employment and their supervision.
Leslie?
Are there other places in statute where the number of advanced practice people can be employed, can be supervised by a physician?
This might be a question more for when we.
I'm just getting it on the table, because I haven't heard of that anywhere regarding PAs and docs or anything like that. But, yeah.
So let's hold that. You can
Yeah.
write it down and we'll come back to it.
Yes, I do, at least from some of the written information provided by the largest hospital, it sounds like there is one radiologist assistant licensed in the state. So I don't think this provision is currently in play, but I think they are looking to ensure that there is an appropriate level of oversight from the supervising radiologist so that they're able to actually be providing meaningful supervision.
It doesn't seem like, and maybe I'm missing it, that this belongs in this bill.
So let's hold that question,
All right.
because that's why I'm bringing it forth. So let's go through, because we haven't actually gotten to the second
Oh.
instance here. So let's finish this
Yeah,
and then
yeah.
we can have a broad.
All right.
And then that's the conversation, I think. All right, so existing subsection B of this says, subject to those limitations in subsection A, the radiologist assistant scope of practice shall be limited to that delegated to the radiologist assistant by the primary supervising radiologist and for which the radiologist is qualified by education, training, and experience. At no time shall the practice of the radiologist assistant exceed the normal scope of the supervising radiologist's practice. A radiologist assistant, I've changed may not to shall not. It doesn't change the meaning, but I think it clears up any ambiguity about whether may not means also may. So radiologist assistant shall not interpret images, make diagnoses, or prescribe medications or therapies. And then here's the new language, but may communicate with patients regarding the radiologist assistant's preliminary observations regarding the technical performance of a procedure or examination and regarding the findings from a radiologist's report. So this was the piece that the chair was talking about, saying we think we got all of the images that we were looking for, but not, and everything looks fine, or there's a concerning image or anything like that. Just was it performed the way they hoped it would be performed? And then they can also communicate the findings from the radiologist report, because the radiologist is permitted to, and that's the scope of their role, is to interpret and report on their findings. So that is that section.
Great.
If there are not questions about the language, then I will.
Yep, so let's stop. So we're gonna come back to Art's question, but overall, not on the radiology section because this is new, but overall, are there any remaining questions?
And there is a little more on the bill if you want to.
Oh, there is? Okay, yep, keep going.
Put it in before the end because
Okay.
it was the report.
Yep,
So we have the report on updating physician licensure processes. This language, which I don't think has changed, has the Board of Medical Practice reporting to this committee and the Health and Welfare Committee regarding options for streamlining and modernizing the physician licensure process, such as alternatives to requiring an original birth certificate as a method of proving identification, the status of obtaining fingerprint-supported background checks, and being able to serve as the state of principal licensure for purposes of participation in the Interstate Medical Licensure Compact, offering provisional licenses pending full document verification, and allowing the board's staff to approve uncomplicated license applications. And then we have the effective date. Everything takes effect on passage except one of the advanced directive provisions takes effect April 1st. Okay,
Great.
now we can go.
thank you, Jen. So, general conversation about where everyone stands on the whole bill, minus radiology. Brian?
Yeah, I was waiting till the end to ask questions, so some of it might be.
Go on, go up. Yep.
No, well, it's not, so neither of these things are specifically in the bill, but they're related to the bill.
Okay.
So one, I'll ask you, one of them is like probably a hard question to answer. Maybe I'll ask that one first. Like, like I noticed we refer to CoV SARS or SARS-CoV and COVID. Do we say COVID-19 in here too somewhere?
In talking about the pandemic, I try
Yeah.
not to refer to the
At
actual.
what point does the virus mutate to not be considered the virus in this bill? Like, and if you don't know the answer to that, then fine. But I just, when I'm reading it, I'm like, we keep extending, this virus keeps changing. And now, like, it would be great to hear from some public health experts, because I'm not here to give testimony, but my understanding is like tests aren't even working anymore, like to detect it for some people. Like, you know, they have COVID, but they have to get like different tests and like, so like it's evolving and mutating. At what point is this virus not covered by the law?
I think for them, I mean, I think that's the reason they actually put the SARS-CoV language in, because I believe that acronym will continue to, although that's a good underlying, that's a good medical question. But so I tried to use COVID-19 or continue the use of the term COVID-19 really to refer to the pandemic, because I think that's when that original disease was identified, and the pandemic name kind of went along with that. There are, I think, maybe a few other places where I've just used the word COVID and not COVID-19. And then I do think there's also the difference between what the virus is and what the disease is. And so I'm not going to be the right person to go any further than that. But I think there are certain things where it really matters what we call it. And I think there are other things where it matters more what the policy is around whatever the disease category is.
For what it's worth, we're probably safe for the next year with this bill. Like, in other words, like, if there is a dramatic change in the virus, we could always, I guess, pass another law, but
I
whatever.
will look around. I don't know if anybody has.
I'm looking around too, and everyone's avoiding eye contact, which makes me,
I think SARS.
What did you say? Just now?
that everybody's avoiding eye contact.
No, not that, but in the year.
We're good for a year with this, and if the virus did dramatically change, we would have to just talk about that and pass a different law or something. I mean,
I think
That's what I thought.
SARS is broad enough.
SARS is big.
Right.
Yeah, it's
SARS has
broad
been around a
enough
long
to
time.
cover all the,
SARS-CoV.
is,
But I think it's
So that would cover the original SARS coronaviruses from years ago.
coronavirus is.
Yeah, but if it says SARS-CoV, does that cover all viruses in the SARS-CoV family?
Coronavirus is broad too.
Yeah.
I think that's the clue.
It's a
There's many kinds of
Right, right. So
coronaviruses.
there's many types of SARS, and this is limiting it to the corona. Is that what the
That's what I
COVID
was
part
gonna
is?
say.
Yeah.
Coronavirus SARS.
Coronavirus
Version of SARS.
is
That is-
also broad.
That is the authority that we're maintaining the authority of the pharmacist to order and administer these SARS-CoV tests.
So as long as SARS is caused by a coronavirus in this current age we're in or whatever, this should cover it. It would
That's-
have to be a
it's-
different virus or.
I mean, that's this one provision, but I think for the most part, things are really more time-based, or they kind of, they're not language that sets the law. They say things like during and after the COVID pandemic. So
Okay, yes, okay, I get
they're
it.
not, yeah, so I think, I mean, it's a valid question, because I think if we said everything was tied specifically to COVID-19, when are we not talking about COVID-19 anymore? So I think the actual legislative language that legal rights or responsibilities tie to is getting further afield from using that terminology of specifically COVID-19.
Well, it reassures me to know that you're thinking about that and that you've pointed out examples and I feel like I can explain to people.
Yeah, I will look through one more time, but it's,
And I think our intent in the conversations we have is that hopefully this is the last time we extend this bill. If there's still something that needs to be done, we will look to having it be permanently done or determine how we move forward from that.
That makes sense.
And I think we've also proven that we can pivot pretty quickly if there's a pandemic.
I mean, we did it in 2 days,
Right.
so.
so there is, I mean, I guess as I'm flipping through this, there is maybe worth just visiting with DFR to see if the emergency rulemaking authority that they have around expanding health insurance coverage for and waiving or limiting cost sharing requirements directly related to, where it's specific to COVID-19 diagnosis, treatment, and prevention, maybe it should be broader than that.
you mind reaching out
No.
to sending me the language? That would be great. Thank you, Jen.
And I will look through if there are similar instances. Some of them, I think, where it's saying things like during and after declared state of emergency in Vermont as a result of COVID-19. I think we're still arguably in that window. But these specific references are an interesting question, so I will.
All right, go ahead, Brian.
So this question, my questions are kind of like probably stressful ones. So this one is probably the more stressful one for some people, which is that, like, I'm reading the purpose of the bill and we tacked on the advanced directives and we even changed the title because of that. So now it says relating to extending flexibility and allowing. And so I feel like this is a COVID, almost like some omnibus COVID e-bill kind of thing. And like, I'm wondering if like it would be germane to add a registry of vaccine related injuries to this bill.
So everything is germane because it's a committee bill. You can put in it whatever you want. I don't believe there are any limitations on germaneness when you're creating a committee bill, or generally in the House, what happens in committee, even in the way of an amendment. There was originally the advanced directive language, not in the very first Act 91, but since then has been included because it was, the remote witnessing was related to the pandemic. Although this would be allowing remote witnesses permanently and electronic signatures is new. So, I mean, I think there are arguments to be made in all directions, and those are policy questions I will put back in your laps.
Okay.
Do you have something on that?
Yeah, I'm thinking about how some of this is so time sensitive. Are we limited in how many committee bills we have? Like if we could start another committee bill?
And so that was gonna be my point. This is time sensitive. This is why I'm meeting with Human Services today. We have to have the governor sign this bill by March 31st. So we are really limited to the additional amount of time we can take on anything. That recommendation, I'd be happy to talk about as a committee. I think it would be way too much testimony before this has to get out the door.
So
And
so
we're
perhaps we could
already-
revisit it.
And we're
Yeah.
already booked for a budget because that has a deadline of March 1st. Bobby.
I was gonna ask Brian, are you talking about what the objective of H189 is?
Yeah, and also, wait, and yes, I don't necessarily like the tone of the emails, but I think that the point of the emails is valid. Like we created a vaccine registry, and the way we did it last year is it was actually added into the budget after it got didn't make it across the floor. So if
We didn't add a vaccine. We've always had a vaccine registry.
Yeah.
That's always been something we've had. So let's talk about
Okay.
it. Let's keep this focused to this bill.
Well, no, and just to finish off, I have contact with David Engel there at the Department of Health, and he says that data is protected by HIPAA. So that's where I'm trying to figure out if we can even do that. Like, you can't publicize that data.
So let's have that conversation offline. Or not offline. I take that back. We
Let's
will
make a
have it
time
on
for it. Yeah,
camera,
we'll make
but
time
on
for it.
another
Yeah.
time. That's what I meant to say.
I'm fine with coming back to it, but I think we should have a discussion about the issue. Okay.
Topper.
So the radiologist assistant, before that individual does it, they have to line up the person that's overseeing them.
They have to have a supervisory relationship, correct?
But before they can begin work,
Right.
but I don't know that the sort of day-to-day exercise of their authority under their role,
Okay, that's the question.
right, I think that's a question for board medical practice or for the radiologists. I don't have an answer to that. Other than I would find it surprising from an operational standpoint, that they had to run everything they did by the radiologist before they did it, as long as they're acting within their scope of practice. It requires the supervising radiologist to be readily available for consultation and intervention, but I would expect there are aspects of the practice that are doable without continuous feedback from the supervising radiologist. But I think it's a good question for providers and the board.
So the intent either way is to have witnesses come in on this section. It will require probably 1 or 2 hours at the most. I can't even imagine that it'll take, an hour to have that testimony, either this afternoon or Friday. So either way, I would like to find a path forward for us to have that conversation. What I want to understand from the committee is if you're comfortable putting into this bill or if you'd rather have it be a committee bill. Art,
You mean the radiologist
Yes.
part? Absolutely. I'd rather have it be a committee bill.
and why is that?
Something other than here. I just don't think it belongs here, just listening to it. But,
Okay.
that would be my opinion on it.
Okay, Mari?
I'm comfortable with it being here. It's, in my short experience, this is often what committee bills look like. They're not necessarily all related pieces, and this does actually relate in terms of access to care and by ensuring that radiology assistants can do certain things will limit delay of care.
Leslie and then Daisy?
I agree that we should keep it because I think we should move it through. For those of us who've had radiology procedures, those are incredibly competent people. And we want to support them and moving this work onward. I totally get your point that it seems like it's a different topic, but this is sort of my understanding, even shorter than Mari's, is that this is what committee bills can do legitimately. So supporting this profession, I think, is worthy.
Daisy?
Same. I think from my experience of having a lot of radiology visits during COVID, this makes absolute sense in terms of expediting patient access to care and facilitating just more immediate access to results. And so I would vote that we keep it where it's at right now.
Anyone else?
Just to say, I'm completely in favor of keeping it where it is right now.
Anyone else?
I'm neutral.
Neutral?
I just feel, I'm fine, I mean, I'm fine with it.
Okay. Yeah, okay.
I wish we could improve it and add things, but it's okay.
So why don't we do this? Why, again, my main goal here on this bill is to get it out of here so that it can get signed by March 31st. Has to obviously go through the Senate. So once I meet with Human Services today and find out their timeline, if we have the hour, if we have the time to take the hour for testimony this week before they're ready, then we will do that based on feedback here. And if it's going to be better for us just to vote this bill out without it in it and come back to it next week, then we'll do that. Does that seem fair to everyone? Okay.
I frankly, myself, I want to get that oversight question
Okay.
answered.
I will make sure someone heard that question and get back to you. Okay. So, Art?
Just a comment on this, and it has nothing to do with whether or not I'm amazed that radiologists and radiologist assistants have so many very tight rules. I'm just blown away by the rules. I didn't realize that we had to get so deeply involved in all this stuff, and that bothers me a little bit. But there's nothing we're going to do.
Right. No, I understand. It is eye-opening, I think, it has been for me being in the legislature and looking at healthcare.
Yeah.
What is in statute and
I mean,
we make it difficult.
yeah.
And I'm sure, some of it is for safety purposes and.
Something must have happened down the road.
Some of it might be, too much, so, but I'm here for it.
All right.
Leslie?
Well, just in the course of my lifetime in doing this, like 40 years, radiology has exploded. It used to be that you just had those flat films that we've all seen with the x-ray, but now it's like fine needle aspiration.
Oh, yeah, they do a lot of work.
Things going on in the radiology world that's way expanding, so that the radiologist is doing the interpretation, but they do need assistance to do the actual work at the bedside. And it's important work and crucial to diagnosis and treatment. So the point is, it's exploded, and this is sort of a result of that.
So, Mari?
Just real quickly, just echoing that amount of oversight is not burdensome, and as someone who lives within tons of regulations and quality and safety provisions, that's pretty
Standard.
minimal, standard.
So in regards to the rest of the bill, is everyone comfortable where we are? And we can, when we get to the point, we can take a vote. I'm not asking for what your vote will be, but everyone's comfortable with moving forward.
Yes.
Yes.
My big hang up with this bill will be the buprenorphine piece. If that's out, then that's one thing. If it's in, that's another.
Okay.
That's,
So we'll leave that up to Human Services and then we can vote accordingly. Okay, great. I appreciate your time on this. I do. It's really important. And so I'll come back to you on how we're going to manage the timing of this to make sure that we get it out of here. And Leslie?
Process question, just to reflect from Art's comment. So there's a drive-through by Human Services. Do they take a straw poll on that language? They come back to us with their straw poll, but then we take the ultimate.
We take the overall vote.
Got it.
Yep, on their language and our language. Yeah. And there was something else I was going to say. I cannot remember what it was. I think it was related to this, so hopefully I'll remember before